Welcome to our latest Hear from the Experts seminar. This series is helping people better understand multiple sclerosis, highlights MS-related resources, plus provides tools and tips to help you navigate your MS journey. With more knowledge and confidence, our intention is to help you learn more about the disease, treatments, research, wellness strategies, our programs here at the MS Society, and much more. My name's Gabrielle Vito, and I'm a person with MS myself. I've been a long-time volunteer with the MS Society of Canada since my own diagnosis way back in 1996. It's a real privilege and pleasure for me to be here with you today to learn more on my MS journey, as well as I act as today's moderator for today's session. Now, before we get started with our presentation, I would like to briefly go over a couple of housekeeping items. Your microphones have been muted and will remain muted for the entirety of the broadcast. This session is being recorded and will be available soon on our website in English. We will also be adding French subtitles to the recording, but that version takes several weeks to become available. All the recordings are available on the website under Nationwide Webinars from the archive page and, of course, on the YouTube channel. Now, if you have any questions for today's presenter, please type it into the chat box on the right-hand side of your screen, and we'll try to get to as many questions as possible following today's formal presentation. We have received some pre-submitted questions that will be getting us started. This session is also being broadcast today on Facebook Live, and we welcome that audience to also type in any questions into the chat box. Now, please note that questions pertaining to specific personal situations likely cannot be answered in this type of a venue, and we recommend that you contact your personal MS healthcare team. Or perhaps you could contact the MS Knowledge Network to address your specific personal questions. Now, speaking of the MS Knowledge Network, we have staff, including an MS Navigator, monitoring the chats, and they will share additional information when and if it's appropriate. Also, please note, as always, that the MS Society of Canada does not approve, endorse, or recommend any specific product, therapy, or service, but provides information to assist individuals in making their own health and wellness decisions. Now, today's broadcast is an opportunity to learn more about how lifestyle choices can affect those with MS and wellness strategies. We're very grateful to Roche Canada for providing sponsorship to make today's webinar possible. Our expert today is Dr. Patricia Coyle. She is the Vice Chair for Clinical Affairs and Professor of Neurology, as well as Director of the Stony Brook Multiple Sclerosis Comprehensive Care Center. She earned her medical degree and completed her residency in neurology at the Johns Hopkins University of Medicine in Baltimore, Maryland, where she also completed a fellowship in neuroimmunology and neurovirology. Her areas of expertise include MS, neuroimmunology, and neurologic infectious diseases, in particular Lyme disease. Dr. Coyle has held multiple leadership positions at the American Board of Psychiatry and Neurology, the American Academy of Neurology, the American Neurological Association, and the National MS Society. She has served as an advisor to the USA Food and Drug Administration and the Institute of Medicine. Dr. Coyle has received research funding from the National Institute of Health, plus the National MS Society. We're so glad that she's here. Welcome, Dr. Coyle. Thank you so much, and go ahead.
Well, I'm delighted to be here to speak to you about lifestyle choices in MS. These are my disclosures. I've really divided this into 10 portions. I'll begin with a background, then we'll talk about smoking and vaping, exercise, body weight and diet, vitamin D and B12, sleep, shift work, alcohol and caffeine, comorbidities, and then I'll summarize. So let's start with the background. This is the concept of central nervous system reserve, brain reserve, and cognitive reserve. Everybody is slightly different. Some people are genetically born with better operational brains, larger brains, more neurons, more synapses than others. Okay, but brain reserve, although it's largely determined by genetic factors, also is impacted by lifestyle choices. Are they healthy? That's good for brain reserve. Are they not healthy? That's bad for brain reserve. In addition, we're all different with regard to cognitive abilities, but cognitive reserve is very influenced by, are you intellectually stimulated? Do you challenge your cognitive brain? Do you do a lot of reading courses, or are you stagnant and not being challenged? That can improve CNS reserve or harm CNS reserve. Why is this important in MS? The degree of reserve plays a role in how well each of us ages, whether we have MS or we don't have MS. It also plays a role in how well someone can withstand the damage from MS. You want to have enhanced CNS reserve. You want better brain reserve and better cognitive reserve. That's why lifestyle choices can help you do that. Now, sometimes I've had patients ask me, what is a wellness program? Well, this is really a very simple list. You don't want to smoke or vape. You want mid-normal vitamin D levels in your blood. You want to be an optimum weight and have an optimum body mass index, or BMI. You want a healthy diet, meaning a non-inflammatory diet. You really want good sleep hygiene. You don't want to use excessive alcohol or caffeine. You want good temperature control. You want a regular exercise program. You want to minimize stress and conflict. You want to try to be optimistic and positive. You want stimulating mental and social activity to keep that reserve in good shape. And you want to control comorbid conditions like vascular and mood disturbances. This is a wellness program. And I want you to think about the treatment of MS as being multidimensional. It's not just disease-modifying therapies. They're very important, of course. They've been life-altering. But it's also treating the acute attacks of MS with high-dose steroids, and in some cases, perhaps moving to plasma exchange for bad attacks. You want to optimize symptom management, of course. And you want to do things that will enhance your central nervous system repair. And this is where the lifestyle choices, following a wellness program, and optimally managing comorbid conditions become so important. So keep that in mind. I consider boosting CNS repair the equivalent of another effective disease-modifying therapy in MS. And everybody with MS is eligible for that disease-modifying therapy. Now let's start with smoking and vaping. And most of the data is available on smoking, much less so than vaping. In a nutshell, verboten, bad, no redeeming quality. Nobody with MS should be smoking or, in my opinion, vaping. Smoking and vaping, what do? They put chemicals into your lungs, a very large portion of the systemic mucosal immune system. It causes inflammation in the lungs. That's bad for MS. We try to decrease inflammation in MS. We don't want to increase inflammation in MS. It turns out smoking increases the likelihood of developing MS by about 50%. It's probably etiologically a factor in developing MS. If you have relapsing MS and you smoke or vape, I believe, you're more likely to transition to secondary progressive MS. Why would anybody want to take that risk? Smoking worsens MS symptoms, increases the degree of disability in MS, decreases the effectiveness of disease-modifying therapy. People that smoke are sabotaging their treatment, increases damage as measured on the MRI scans of the central nervous system, and is associated with a higher death rate. And it turns out passive smoking is also negative. The individual doesn't have to smoke. They just need to be exposed to it and breathe it in and put those chemicals into their lungs. So passive bystander smoking, it's not quite as terrible as smoking yourself, but it's not good. In contrast, oral tobacco doesn't have the effect. So it appears to be putting chemicals into the lungs and causing their inflammation that is really at fault. So what about cannabis? I have no problems with cannabis. It failed to help MS damage, so it's not an MS disease-modifying therapy. It may be helpful in some symptoms. There's a little bit of data for pain, for spasticity, for overactive bladder. But what you cannot do is you cannot smoke or vape cannabis. If you're doing that, you're sabotaging. That's smoking and vaping. So you cannot use cannabis with MS, in my opinion, and smoke or vape it. You need to do another form, gummy, oil, whatever you want, not smoking or not vaping. And although the data is not clear, I'm telling you right now, in my honest opinion, vaping is as bad or maybe worse than smoking. That's what the preliminary data is suggesting, so don't do it. Don't do it. Now, this risk of smoking on MS is reported to be higher for men than women, more for current smokers than past smokers. If you stop smoking, the lung starts to repair itself, and it really covers all ages. Well, why is tobacco so bad? It contains a lot of toxic poisonous factors. Carbon monoxide, nitric oxide, hydrogen cyanide, bad stuff to be putting in your body, bad stuff to be putting in your lungs. It leads to increased respiratory tract infections. Having infections is not good for MS. We've estimated about a third of MS attacks are preceded by some sort of infection, like even a mild cold, that upregulates the immune system and leads to the breakthrough attack. So you don't want more respiratory infections. It directly damages lungs. It causes active airway inflammation. It causes the immune system to upregulate. You can see it in lymphocytes and monocytes and other cells. You even have genetic changes that occur with smoking. You have blood flow, microvascular, small blood vessel, blood flow changes. You're really causing oxidative stress, which is bad for tissue. And there's even some data that stimulation within the lungs can actually induce inflammation within the nervous system. So it's really not a good thing. And can it be protected? Can you be protected by being on a DMT? No. It turns out that if you smoke on a DMT, even some of the high efficacy ones like natalizumab, smokers showed a 38% increased rate in relapses compared to those that didn't smoke. A similar finding on interferon beta. You're nullifying the effect. You're more likely to have breakthrough activity if you smoke, even if you're on a disease-modifying therapy. Now, the dose response for MS risk in a smoker is cumulative. So the longer you smoke, the higher the risk, and even with passive smoking. When you stop smoking, that risk slowly goes down, so you actually can reverse it. And there are some genetic associations. There may be genetically people that are more vulnerable to have the negative effects of smoking on MS if they have certain genes, and that those studies are ongoing. What do we know about vaping and e-cigarettes? We don't know as much, but to me, what we do know preliminarily indicates it's as bad or worse than smoking. Vaping involves aerosol generating devices that heat rather than burn a solution of solvents and flavoring plus nicotine. That's what an e-cigarette does. It creates fine particles. That's very similar to tobacco smoking. These fine particles deposit in the lungs, similar to tobacco smoking. They irritate the airways. They cause inflammation. They cause mucus hypersecretion. Vaping has been linked to worsening asthma, worsening COPD, worsening cystic fibrosis. They produce changes in the immune system, upregulating it, that in some studies have been more severe than the upregulation you see with regular cigarette smoking. So vaping, no, absolutely negative. Don't want to do it. Let's move on to exercise. This is from the National MS Society in the United States that put together an expert opinion panel, and they published recommendations on exercise for MS individuals in 2020. These are pretty positive and helpful statements. They endorse and promote the benefits and safety of exercise and physical activity lifestyle for all MS individuals. So there's no such thing as saying, oh, you have MS, you shouldn't be exercising. Wrong. Just the opposite. Everybody with MS should be exercising. They recommended an early evaluation by an MS specialist in physical therapy or occupational therapy or exercise sports scientists to establish an individualized one-on-one exercise, lifestyle, physical activity plan. They encouraged at least 150 minutes a week, that's 2.5 hours a week of exercise, and or at least 150 minutes per week of lifestyle physical choices, taking into account comorbidities and symptom fluctuation. Expect that the progress with exercise will be gradual. It's not going to be sudden. It's not going to be noticeable immediately, but you're building on a gradual, slowly conditioning exercise. You make referrals as appropriate if the course of MS changes. And even in MS individuals with limited physical mobility, exercise should be facilitated by a trained assistant. Even if you're wheelchair bound, you should be exercising. This was a resounding endorsement. Now, how does exercise help? It seems to impact in a positive way on minimizing damage, pathological damage from the disease. It certainly benefits deconditioning, and it helps comorbidities, and it's likely a combination of these factors that help MS. You know, keep in mind, physical deconditioning, you can take a healthy control and make them immobile for a couple of weeks. They'll get weaker. Their balance will be off. When they try to exercise, they will develop palpitations and shortness of breath. This is a healthy control. That's how bad physical deconditioning and lack of exercise are. So it's very important. It's a use it or lose it type of thing. It's very interesting. Functional MRI scan is a research tool. It looks at circuits that are used in the brain. So this would not be a typical MRI scan, but a functional MRI scan. It turns out exercise improves functional MRI scan, improves circuit use of the brain. Actual physiologic changes on the brain MRI are occurring with exercise. And those with higher cognitive reserve, like we talked about, and physical activity, they had less severe MS. And it may be that high intensity interval training is better than continuous moderate training. But these are very important features. If you're exercising and trying to tell an individual what they should do, the prescriptions have to be individualized, adaptive, change over time, and progressive. And there's aerobic exercises and resistance exercises. Aerobic exercises are bicycle, stationary bicycle, or exercises of the limbs, arms or leg, or on a treadmill, or aquatic exercise. The resistance exercise is sort of like weight machines, often done in a seated position with different repetitions. Both are valuable, but I'm going to put a particular emphasis on the benefits of aerobic exercise in MS. This is just one study of progressive MS patients, primary progressive, secondary progressive. The EDSS was right in the middle range, 4 to 6, so they're having difficulty with walking. And they were randomized to an individually tailored training program over 8 to 10 weeks, 2 to 3 times a week, versus a waitlist control group that didn't do that. And they found with the exercise significant improvement in aerobic fitness for those that did the stationary bike. Both the stationary bike and arm exercises were associated with significant improvement in the 6-minute walk test, and also improvements in cognitive function with verbal learning and recall, decrease in depressive symptoms, and decrease in fatigue with exercise versus the control group. The patients were getting better with exercise than the control group. I think this is a fascinating study. It's one of several that are accumulating that really are saying exercise can truly improve MS individuals. Now let's move to body weight and diet. So adolescent obesity increases risk for later MS. It seems to be adolescent, not before age 10 or 11. So it seems to be a critical time period, and girls may be more affected than boys in this case. It's been estimated that 25 to 33% of MS subjects are obese. Obesity is an inflammatory state. An inflammatory state is bad in MS. Weight loss decreases the inflammation. Weight loss also, this is not just for MS, decreases risk of stroke, heart attack, diabetes, some cancer, and it decreases the risk of death. That's pretty good. You want weight loss. You don't want to be overweight. What does being overweight do? It provokes inflammation. It provokes hormones that may be negative for the immune system in MS. It also has influence on what we call the gut microbiome, and likely nutrition is playing a role. And I'll come back to the gut microbiome in just a minute. So how would you evaluate whether somebody's obese? Well, you could do a regular weight. You can do a body mass index, a BMI, which is the weight divided by the meter, weight divided by the height. It gives you a numerical number. So if you have a BMI less than 25, you are not overweight. But if you have a BMI 25 to less than 30, you are overweight. And if you have a BMI of 30 or higher, you're obese. Most doctor visits will automatically include a BMI, so you want to ask what your BMI is to know where you stand. You can also look at the waist circumference. Truncal obesity is bad, by the way. Truncal obesity is bad. So you measure the waist at the level of the belly button, the umbilicus, and if you are 40 inches or more in men or 35 inches or more in women, that's associated with health issues, whether you have MS or not. And if you have a metabolic syndrome, at least 3 or 5 factors, that's bad news. Hypertension, high blood sugar, excess weight body fat, increased triglycerides, or decreased high density lipoprotein cholesterol, which is a good cholesterol. If you have 3 of those 5 or more, you have a metabolic syndrome. You're at increased risk for heart attack, for stroke, for vascular disease, etc. So you want to make sure you don't have a metabolic syndrome, or if you do, make sure you get it treated. So obesity is an inflammatory state. You see inflammatory immune factors and inflammatory lipid-related hormones like leptin that are involved. A high BMI changes the immune system and actually changes some genes in a bad way for MS, a detrimental way for MS. And even if you're on treatment, you're more likely to have breakthrough activity if you're obese. So the disease-modifying therapy can't conquer the negative effects of obesity. And in this pediatric MS study, they had 32 pediatric MS versus 67 controls. They showed evidence of increased inflammation consistent with obesity in the pediatric MS affected individuals compared to the controls. There was also a NARCOM study. That's a big North American registry. You've probably heard of it, where patients will fill out regular questionnaires on their MS. Well, increased waist circumference was consistent with abdominal obesity, was associated with a 47% increase in having more severe disability from MS. And in a BMI matched MS versus control group, so this is the body mass index, presumably you were taking an equal group there. Even so, the MS individuals, the men, showed less whole lean body mass and more fat mass and body fat, even though they had the same BMI as a match control. They showed problems with a bad obesity profile, so it didn't make up for it. And then there are examples of obesity with an altered lipid profile being associated with increases in central inflammation, which would be bad for MS, and associated with increased disability even at the first diagnosis of relapsing MS. So obesity is bad news. This is an interesting study. It looked at obesity as measured by increased BMI and increased triglyceride levels. That was associated with more likely to have clinical attacks of MS. If we look here, we have normal BMI in red, overweight BMI in the blue, and obese BMI in the green. And we're looking at the likelihood of having a relapse. And it's most likely in the high obesity group, in between in the overweight group, and lowest for breakthrough activity in the normal BMI group. So a clear association with being overweight and having greater MS disease activity breakthrough. It's just like a bad thing. Well, what about diet? There is no proven best MS diet, and dietary studies are very difficult to do. But in general, part of a wellness program is an anti-inflammatory diet. And in an animal model of MS, they can show diet influences that animal model disease called EAE via manipulation of the gut microbiome. Now, that's an animal model. That's not MS. Here is a whole list of specific diets that have been proposed for MS, ranging from ketogenic to swank to McDougall to calorie restriction or even fasting, to the Mediterranean, to the Paleolithic and Wiles, to gluten-free, to the Atkins low carbohydrate, to a high fat but with polyunsaturated fats, or to a low sodium diet. None of these have been truly validated to say you should be on this diet, but all of these would be considered anti-inflammatory diets. And that's really the key thing. You want to be eating healthy. This is a very recent review, a systematic review of the literature of diet studies in MS, and they found 12 diet trials that evaluated 8 diets in MS: low fat, Mediterranean, ketogenic, anti-inflammatory in general, Paleolithic, fasting, calorie restriction, and control of a usual diet. And they found that 3 diets decreased fatigue versus controls. They also had 2 diets that increased quality of life, both physical and mental, over controls. However, to be honest, they had to say, as we judge the quality of these dietary studies, they're low quality. So we can't say that there have been definitive studies that would say this is the best diet to follow, but there's no doubt that a healthy diet is important in MS. An anti-inflammatory diet is important in MS. Why? Because dietary factors manipulate the immune system. Saturated animal fats, which in general are bad, activate the immune system. They're going to be inflammatory. Whereas short-chain fatty acids, which are more plant-based fats, favor downregulation of the immune system. Polyunsaturated fatty acids decrease inflammation. You have other factors, so your diet can really manipulate your immune system, and that's probably a major factor. In fact, there was a study that looked at genetics, genes, and what are called SNPs changes. They found 70 changes that were associated with that BMI, that body mass index, and risk of MS. They were genetically associated. The increased BMI genes were also the genes that were associated with increased risk of MS. So the ones that made you more likely to have an elevated BMI were more likely to be associated with your getting MS. So there's definitely an important relationship between diet and MS. And I want to put in a word for the gut microbiome. This is in a very preliminary early stage of research in MS, among other diseases. We know there's an important connection between our gut and our central nervous system. There's bidirectional communication. Things going on in the gut can affect what's going on in the brain and vice versa. Now, it turns out at birth, our gut is not colonized with any infectious pathogens at all, with any organisms, but it starts at the time of birth, and by age one, it's completely colonized with several hundred unique species per individual. So none of us have exactly the same gut microbiome. Now, the flora in each of our guts will be influenced by many features, but by diet, very influenced by diet. And you can see subtle changes in the gut microbiome in individuals with MS. And the really intriguing question is there a gut microbiome that promotes development of MS? Is there a gut microbiome that prevents development of MS? Could we manipulate our gut microbiome to actually treat MS? We don't have the answers to all of those yet, but the answers may turn out to be yes. And diet would be one very important thing to manipulate the gut microbiome. So this is a very interesting research question that's in a very preliminary stage at this point in time with regard to what is the relationship between the gut microbiome and getting or not getting MS or severity of the disease. Now let's turn to vitamin D and B12. You know, vitamin B12 is probably one of the most important vitamins because if you truly have a deficiency really low, it damages nervous system tissue. It can cause dementia. It can cause optic nerve vision loss. It can cause degeneration of specific spinal cord tracts that can mimic primary progressive MS. It can cause a peripheral neuropathy. Thank goodness it's lucky that most of the individuals are not truly B12 deficient. However, if you run a low normal B12 level, meaning below 400 picograms for MS, a minority of individuals have a relative B12 deficiency. Now, I can just tell you for myself and for my MS patients at the Stony Brook Center, I will not tolerate somebody running a B12 level below 400. I will have them supplement this as a single multivitamin, so to speak, taking daily B12 to raise their level above 400, because I do not want anybody having a relative deficiency that might be adding on to nervous system tissue from their MS. So I think that's an important concept for B12. Now, what about vitamin D? There's a strong link between vitamin D and MS, at least in Caucasians with MS. The epidemiologic studies from large cohorts have said if you're a young adult with a high vitamin D level, you have a reduced risk of MS. The relative risk for MS seems to increase if you have a below normal vitamin D level. There was a study that showed that vitamin D during pregnancy, if it was very, very low, was associated with an almost twofold increased risk of MS subsequently developing in the offspring from that pregnancy. There was another study that looked at newborn levels of vitamin D and found that low levels of vitamin D in the newborn were associated with a later risk of MS. This was all confined to Caucasian populations. The same thing may not hold for African Americans, for Blacks, where they seem to be able to have low levels of vitamin D, but still have reasonable bioavailable vitamin D and don't seem to show vitamin D deficiency issues. So these remarks about vitamin D are really most pertinent just based on the data that we have for Caucasians with MS. So vitamin D deficiency below normal, and the normal range is about 30 to 100. Below normal is linked to increased risk of MS, at least in Caucasians. The vitamin D genetic risk score identified in pediatric patients was associated with increased risk of breakthrough relapses. Now they've looked at, so it seems like a low vitamin D level in Caucasians increases your risk for MS. Is there any benefit from raising up the level? Well, I think you would want to put it in normal range. If a low vitamin D led to the development of MS, I think you would want to correct it. If you run medium to high normal, does it actually combat MS damage? We don't have a final answer on that. Some clinical trials have been negative in being able to prove that vitamin D supplementation improves the ongoing disease process. But some observational studies have suggested that if you maintain, let's say, a level in the 50-60 range, it can actually benefit with decreased relapses and less MRI damage. And currently our approach is to normalize vitamin D in MS, and we aim for a level of about 50 to 60, at least in Caucasians for sure. And in general, we'll try to normalize for everybody, but won't really push. One thing to be concerned, slightly aware of, is if you start to supplement vitamin D, you're going to absorb more calcium. And if you have a history of kidney stones, most of them are calcium kidney stones. So you just want to be aware of that and not lead to precipitating calcium attacks. What about ultraviolet radiation and sunlight exposure? And this is pertinent to the equator and moving north or south. The top ultraviolet radiation sunlight exposure would typically be at the equator and lessen as you move away from it. Well, we know that the equator in most of the studies, and they're limited studies, has very little MS, but MS becomes more common as you move away to higher latitudes. This it may be partially explainable by UV radiation and sunlight exposure. Decreased UV radiation and sunlight exposure in winter increase the risk of MS in a very large U.S. technology cohort study of close to 40,000 individuals. That was seen across all age groups, so long as they were less than 40. Decreased ultraviolet radiation sunlight exposure increased the risk of MS. In another study, increased ultraviolet radiation exposure during childhood and early adulthood in the Nurses' Health Study, and you can see the large numbers there, decreased the MS risk. So this is not absolutely definitive, but there are these interesting studies suggesting ultraviolet radiation may be protective against developing MS. Sleep. I can't say how important sleep is for a wellness program. So you want a lifestyle choices that promote sleep. Sleep problems are associated with and may play a causal role in depression, heart disease, pain, and memory problems. Sleep health is linked to morbidity and mortality. If you have bad sleep, you're going to have greater morbidity and greater mortality. Lack of sleep increases risk of obesity. We've heard how bad that is. Heart disease and infections. That's bad for MS. There's something called the glymphatic system. This is a system that attaches the spinal fluid to the perivascular spaces. This is a washout system. It pumps out waste products. This accelerates and is strongest during sleep. The central nervous system, in particular the brain, is restoring itself during sleep. It's getting rid of all the waste products so it can operate at the highest level during the day. If you screw up your sleep, you're screwing up with that garbage collector role. That's not a good thing. Now, it turns out when you look at formal sleep studies, they're increased in MS. Things like insomnia, sleep apnea, restless legs, REM sleep behavior disorder with very vivid dreams. It's been reported that anywhere from 40% to 70% of MS individuals have poor sleep quality, and that will be associated with greater fatigue and poorer quality of life. So sleep hygiene and sleeping well is a very important key component of a wellness program. Shift work. This is preliminary. Shift work is work outside of 7 a.m. to 6 p.m. So it's work in night times and evenings. It accounts for about 16% of jobs. It could be a factor in MS. Shift work has been associated with a higher risk of having autoimmune diseases, and there are 2 studies that have suggested the risk for MS may be greater in those that are involved in shift work, particularly under the age of 20, although in a recent analysis of the Nurses' Health Study, they didn't find a clear association with MS unless they had been in shift work for 20 years or longer. Okay, so just stay tuned. More work needs to be done. What about alcohol and caffeine? You know, let's say alcohol and caffeine, if you do excess, that's bad. That's obvious. But not all presumptive negative factors are bad. The alcohol results with MS have been inconsistent, either no impact on MS or even a dose-dependent decreased risk in MS. And coffee data suggests higher quantities may decrease MS risk. So these are 2 features that I think are not bad for MS, alcohol and caffeine, but must be used in moderation. Moderation is a key factor. Finally, what about comorbidities? Comorbidities refer to other conditions. So MS is one health condition, comorbid, hypertension, depression, etc. would be others. The older we get, the more likely we are to see other comorbid conditions. They're bad for MS, okay? So MS shows an increased risk of comorbid conditions compared to matched controls, particularly depression, anxiety, hypertension, hyperlipidemia, chronic lung disease. And autoimmune diseases that are increased in MS include thyroid disease, asthma, type 2 diabetes, psoriasis, and rheumatoid arthritis. This can occur before the onset of clinical MS or after the onset of MS. And we don't know if it reflects a direct causal effect or associated risk factors like shared gene propensity or heterogeneous effects. Comorbidity has potent negative effects on MS. So there are studies that say it delays the diagnosis, it increases the degree of disability that's shown at the time of diagnosis, it gives you a worse prognosis if you have MS, it increases your disability worsening, it increases your healthcare use. There's a dose effect that shows increased mortality. It gives you a poorer quality of life. And comorbidities may differ based on sex. This was just one study that looked at comorbid conditions in men, the light blue, and women with MS, the dark blue. And look at the difference there. So you always have to be aware of sex and ask, is there a different impact? And here are examples of comorbid conditions differing based on sex. This was a meta-analysis that looked at MS and found that MS showed a almost threefold higher death rate than the general population, mainly due to comorbid conditions like cardiovascular disease or suicide from depression or infection and respiratory disease. And the disease-modifying therapies could lower this death rate, so they were actually helping survival in certain cases. But we do know that overall, the lifespan is slightly shortened for MS versus a matched control by 6 to 7 years, mainly in the more debilitated MS and those that have a lot of comorbid conditions. So just to speak a little bit more about this, depression is probably the most frequent comorbid condition in MS. This was a large study from the United Kingdom that looked at 12,000 MS individuals, 72,000 matched controls. 21% of MS had baseline depression compared to only 9% of the control group. The MS versus control had a higher risk to have vascular disease, whether or not they had depression, but the risk for vascular disease was highest in those that were depressed and had MS, particularly females that had depression. They were statistically significantly at greater risk for vascular disease. The all-cause 10-year mortality was increased in controls with depression by 1.75-fold increase. But if you had MS and didn't have depression, your all-cause 10-year mortality was 3.88-fold increased. And if you had MS and depression, it boosted up to 5.43%. So the comorbid condition of depression was having much more impact if you had MS than if you didn't. And it seemed like the MS status and depression were synergistic. So they concluded that depression in MS was associated with a higher risk of vascular disease and mortality. And they asked, if you treated that comorbid condition of depression, would that patient be at lesser risk for vascular disease and lower their risk of mortality? And it really introduces this concept of the importance of recognizing and optimally managing treating comorbid conditions. So to summarize, all newly diagnosed MS patients should be counseled on the importance of a wellness program, key lifestyle choices, importance of identifying and treating comorbidities as they may develop over time. MS individuals should quit smoking, correct any vitamin D deficiency, target optimal body weight, implement an exercise program, and assure intellectual stimulation. Now, I could say that for everybody. You don't have to have MS for that. They should review diet and sleep habits. They should do a vaccination assessment. And these issues should be tracked over time individually, repeatedly emphasize. This approach can be considered a natural disease-modifying therapy in MS. And I'll stop there and we will open it up to questions and answers.
Well, wow, Dr. Coyle, what a fabulous presentation. I'm so glad that I was here for this today. As you've said, it is time to get on to questions now. So I will get us started with two of the issues that you've touched on, and that is both vitamin D and B12 levels. The question is, how are those levels identified? Does my doctor order a blood test?
Very simple blood test. For vitamin D, you want a vitamin D 25 hydroxy level, and that's what you can follow. The normal range in most labs is about 30 to 100. You don't want to be too high, but you don't want to be below 30. And you would use the blood test results of vitamin D 25 hydroxy to tell you how much you should be supplementing. I put patients on vitamin D3 over the counter. You don't need a script. You're taking it daily like a multivitamin.
Excellent. Well, then that answers the next question: is how do you take this? How do you address the deficiency if it is there? Like, so you've answered that one. Over-the-counter supplements. What other supplements do you recommend?
What I routinely test at least once a year is vitamin D25 hydroxy and vitamin B12. I don't really recommend any other supplements because I don't think there's data to support that. So let's talk about somebody, if you had a folate deficiency, that would be a very good thing to supplement. If you had somebody with a history of alcohol abuse, something like thiamine, vitamin B1 becomes very important because it can cause neurologic disease. So it might change based on the setting, but for somebody who is otherwise following, a reasonable, healthy lifestyle, to me, the vitamin D25 hydroxy and the B12 are the major things. Everything else may help, but there's really not great data proving it helps.
Our next question is also a topic you touched on already today, and that's about sleep. The question is, sleep is important, but if someone's having trouble both falling asleep and staying asleep, so they choose to take a sleeping aid, in your experience, could this type of complementary therapy be addictive and possibly harmful?
So first of all, the data has suggested that most of the prescribed sleep medications don't continue to work. So they're used temporarily if you're traveling, going to very different time zones, etc., and you would not continue them in general. There are over-the-counter or more natural aids like melatonin that people can certainly take. And maybe it will be justified with some of the newer medication to take a sleep medication if you are really having a problem. But what I would urge is if you have a noticeable sleep issue, you should probably be seen by a sleep neurologist. You want to make sure you don't have a formal sleep disorder. Maybe your sleep hygiene is really poor. There are things like you're not supposed to take activating agents like caffeine right before you are going to bed. You're not supposed to nap during the day. If you can't fall asleep at night, you don't want to have reversed your sleep-wake cycles. So I'm not so worried about getting addicted, but it's the recognition that I have a sleep disorder. Let me figure that I have disturbed sleep. Let me figure out what's causing it and get it solved. And maybe you need to be seen by a sleep specialist in that case.
All right, our next question is about the efficacy of these natural DMTs, as you've described, these lifestyle choices. How, I'm not going to get specific, this person's question is quite specific, and they recognize that it'll mean different things for different people. But in general, in your practice and in your experience, people who follow these lifestyle choices that you recommend, does that make a difference over the course of their MS?
I have to say yes. Now, understand, I presented a little bit of some of the positive trials. There's accumulating data, so you can go to the literature and look it up, and they'll do a meta-analysis. Now, remember, I was quite candid. The dietary studies are viewed as low quality. What that means is that you can't say definitively, this is the best diet to be on. I feel confident about that. But you have accumulating data, not just in MS, but in non-MS individuals, that exercise being the optimum body weight is critically important health-wise. I indicated a study that showed changes in brain function in a positive manner with that, improvement in symptoms, as well as walking ability. And there are accumulating studies that are showing that. So I think this is a pretty accepted thing. We'll get more and more data as time goes by. So yes, I can speak very definitively. I counsel patients and we talk about that. You could actually do it in non-MS individuals as well, quite candidly.
All right, our next questions come from Facebook Live. And this one is again about a supplement. Does omega-3 play a role in managing relapsing remitting MS?
I'm going to say it's not a proven role. It's not proven. I know a lot of patients take it. That's not a problem. In theory, omega-3, omega-6, plant-based fatty acids are the healthier fatty acids. You want to cut down on saturated fats and red meat type of thing. Those are the ones that are much more inflammatory to the immune system. But I can't say that you have documentation that taking that has a benefit. Not really shown at this point in time, in my opinion.
Okay. And our next question from Facebook Live has to do with depression. In MS, is it thought to be more physiological, a result of demyelination in specific brain areas, or is it more psychological?
Well, as I mentioned, depression is probably the major comorbid condition in MS. There are different types of depression. So you really need to go through the weeds a little bit to work that out. So there may be an immediate depression and being given a diagnosis of a neurological disease that we don't have the ability to cure, although for the vast majority, it's eminently treatable. You can have depression that's a side effect of medication that you're taking. You may have a depression because you actually have comorbid depression as something that you need to deal with along with your MS. So there are multiple things that might cause depression. The bottom line is that there's a recognition of depression and getting optimized treatment for it, not ignoring it. That was the point that I was making. Consider it a comorbid condition if you think that it's lasting. It wasn't just a very temporary thing. There was a death in the family of a loved one. You feel depressed, but then you get over it. That's a whole different issue. But if you are living with depression and you have MS, you cannot ignore it. You need to make sure it's optimally managed because it's going to hurt your MS if you don't do that. That was the point of the comorbid discussion here. It's part of lifestyle modification to boost a wellness program to have patients do the best they can with their MS.
Now, speaking of doing the best we can, our next question is about exercise. Yoga is the topic. It's often given as a good exercise for people with MS. Could yoga replace an aerobic exercise, or should it be added to that 150 minutes of aerobic exercise that you mentioned, recommended weekly?
I think yoga is excellent. It can also help with balance. There is some data suggesting a benefit in MS. Would I want to do yoga as my only aerobic exercise? No, I would not. If you get the sense, it's sort of like the more you do, the better. If you're doing daily exercise, to me, that's even better. Okay, it's almost like not too much exercise that you can do. You should enjoy what you're doing. Okay, you shouldn't do something that you hate or you're not going to stick with it. But certainly, I think yoga is fine to include in that umbrella.
All right, pardon me, I'm choking. There we go. Am I back? I'm back. All right. Our next question comes again from Facebook Live. Can appropriate lifestyle choices help substitute expensive medications for MS, which are exorbitant in price, even the generic ones?
So I don't know if that question is being asked about the disease-modifying therapies. I'm assuming it is.
Fingolimod?
Yes, that's a disease-modifying therapy. So look, the disease-modifying therapies are very expensive. They're too expensive. The U.S. pays more than anybody else, way more than Canada, I'm sure. Nobody pays the list price. The third-party payers make a deal, and they buy in bulk, and then they may or may not sequence, et cetera. So no one is paying out of pocket or virtually nobody is paying out of pocket for these medications. Do lifestyle choices replace an appropriate DMT? No. Okay. The DMTs have been proven in phase 3 trials to decrease the damage, the clinical expression of the disease. What I would argue is that they are a second DMT that everybody can do, that is virtually of no cost, that no matter how you are on the MS spectrum, you're eligible for that. It's going to help you age better. It's going to help you less likely to get Alzheimer's disease. It's going to help you less likely to get vascular disease. So it's a win-win situation. So no, it can't replace an appropriate DMT, but you don't want to ignore it. It's very important. It's an alternative DMT to add on to optimize the therapeutic response of an MS individual.
All right, our next question has to do with another sort of alternative therapy, and that's hormone replacement therapy. The question is, during menopause, sexual function can decrease. Will HRT or another complementary therapy help?
So I think hormone replacement therapy, there's limited literature on it. You would talk about going to hormone replacement therapy if you had menopausal symptomatology that was causing you such suffering that taking the hormone replacement actually helped it. And there is data suggesting that it can lower perimenopausal symptomatology, and people have said, gosh, my MS symptoms that can mimic perimenopausal also seem to be a little bit better. That having been said, the studies that tried to look at estriol with or without progesterone as treatment for MS, in my view, have been disappointing to date.
All right, our last question.
They're tested as disease-modifying therapies, by the way, and it's not seeming to pan out.
All righty, our last question that we have time for today, I'm going to fire at you, Dr. Coyle, is for general health, is it important to keep the immune system strong? Is boosting the immune system harmful and not recommended for people with MS?
There's no immunodeficiency that's been documented in MS. The problem seems to be it may be over-responsive. And if you look at our DMTs, most of them are immunosuppressive. So suppressing the immune system helps to be a benefit. The immunomodulators, and I define that as not being immunosuppressive, would be glutarimer acetate and the interferon betas, the needle injectables. So it seems like the immune system may be overactive in MS. So therefore, you would not want to be deliberately causing boosted inflammatory responses. That's the whole reason for not smoking, for not being obese, etc. Probably not a smart idea in MS.
Excellent. All right, well, that brings us to the end of our time for questions. Thank you so much, Dr. Coyle, for your insights and your experience.
I enjoyed it.
Really appreciate your time today. All right, well, as we wrap up today's broadcast, we want to remind you about the MS Knowledge Network. It is staffed by trained navigators who provide consistent, quality information and support. You can connect by phone, email, or live chat through the MS Society's website. We know that all your interactions and information is trustworthy. Navigators can help you learn more about the programming and resources that we offer at the MS Society to support individuals and their families affected by MS. The navigators can also help you find other community or government supports and programs, plus so much more. For information and support, always know you can reach out to the MS Knowledge Network. Now, if you'd like to sign up for the monthly e-newsletter, an MS Navigator can help you with that as well. When you receive the e-news, you're kept up to date on the latest MS research and treatments, the Society's programs and services, fundraising and volunteer opportunities, personal stories from people affected by MS, and so much more. It's all delivered directly to your email inbox each month. Now, we also invite you to be a part of the MS community. We encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. These days, connecting with each other is more important than ever, and information is available on our website at www.mssociety.ca. Volunteers are an essential part of the support we offer to Canadians affected by MS, and the demand for assistance through our one-to-one peer support program and peer support groups is growing. We need more volunteers to reach as many people affected by MS as possible. If you'd like more information or you're interested in getting involved, please reach out to us. The email is volunteer@mssociety.ca. If you have questions or need support about this webinar or any of our educational activities, you can reach out with a new email we have, which is called education@mssociety.ca, and it's right there on the screen in front of you. Now, very soon you will receive a survey by email about today's webinar, and we encourage you to please fill that out. For the Facebook Live audience, the link to the survey is already available in the chat. We ask that all viewers complete this survey. The information collected from the evaluation will let us know if today's discussion was valuable to you and what topics you would like to see covered in the future. It will only take a couple of minutes, and your feedback goes a long way to helping us plan for future educational sessions. So on behalf of the MS Society of Canada, we send a big thank you to Roche Canada for providing sponsorship for today's broadcast, and thanks to all of you for tuning in for today's webinar, and of course to Dr. Coyle for her valuable insights today. Take care. Bye-bye.